It's a great pleasure to be here, and really what you feel in this old and historic building is that we are going into the future, and that is the main message here. And I think I will just prepare a little bit the way for later discussions on biologics, which will even lead us further. Looking into precision medicine in chronic rhinosinusitis, where are the unmet needs? What do we do not know? And I tell you, I always say, you have solved one question, you get at least 5 more by solving one of these questions. The principle of precision medicine was certainly very nicely illustrated by Jasmine. What we are looking at is not clinical phenotypes so much, but trying to understand what molecular mechanisms of disease are there. Then we have to find diagnostic tools, because if we cannot diagnose these mechanisms, they are not of great value to us. And that's an important step in our way of maybe new treatments and using them in absolutely the right patients, so we can predict in that patient that there will be a therapeutic response which is superior to other therapeutic possibilities we have. Once we are there, we can fully implement precision medicine. At the moment, we are on the way to that stage. How do these patients I'm talking about look like? This is chronic rhinosinusitis. Young man, actually, he started to develop nasal polyps, bilateral, with 14 years. When I saw him first time, he had a full-blown picture of polyps. The whole sinuses were filled with polyps. You can see some rests of bone of this very nice sinus system that was there. When I met him with 19 years, he had already 3 surgeries. He had polyps in the middle ear, and of course he couldn't hear very well because of that, and also he had severe asthma. And this polyp growth very early in his life actually led to hypertelorism, so the eyes were pushed aside and the middle face was larger. We can call that Vokes syndrome. And we feel very fine that we said, wow, this is a Vokes syndrome, we know the literature, great. But what is behind this disease? What is maybe different, maybe similar to another patient? This patient is 43 years old, or 46 years old, since 12 years, very typically late onset disease, had already 3 sinus surgeries, and still, as you see here, suffers from polyp growth, nasal obstruction, secretions, post-nasal drip, no smell, and also has moderate to severe asthma. Since 5 years, has an aspirin exacerbated respiratory disease, and is on inhalative and oral glucocorticosteroids, and still has this disease. So we can call that aspirin sensitivity, maybe, or aspirin exacerbated respiratory disease. We are again happy that we have a name for it. We can name it, and we think, well, the leukotrienes and prostaglandins play a role here, and this is a specific mechanism. But actually, what is behind both of these diseases is more or less an eosinophilic type 2 driven disease, which might give us a way of treating both diseases with a very similar approach, for example, by biologics in the future. As you have seen, this is just for the surgeons among us, these patients had 3 surgeries. Well, I did the 4th surgery, I have to admit, but I'm quite sure that this is not a long-term solution for these patients. So what we have to try is to come down from the phenotypic level that we see in the clinic to understanding pathobiological mechanisms, endotypes. The question is, how do we do that? And there are, in the future, specifically in the field of asthma, a lot of studies where that has been tried. And I have to say, I don't like these studies too much because they really put together pathomechanisms, clinical data, a lifetime of patients, and you get a sort of a mixed bag, and very often you find what you want to find. So we tried to do a totally different approach, and we just looked at T helper cells, especially some cytokines that we could measure, and let all the clinical pathways or clinical parameters out until we have these endotypes, and then go back to see what does that actually mean clinically. Why do T cells help us? Because they determine the kind of inflammation to a great extent. And this has been proposed and shown by Chesmiakis already. There are different T helper cells, and what we have to understand that it's not like there is only one T helper cell in a certain situation. Look at that. This is control mucosa. You have Th1, not very much Th2, probably not allergic here, Th17, Th22, T follicular helper cells, T regulatory cells, and there is this gray field where we do not know what these T cells actually do. That is normal. There is a coexistence of different T cells and their pathways. If we go to chronic rhinosinusitis without nasal polyps, there's not much change. A little bit of type 2 comes in, Th2. But if you look at nasal polyposis, again, a lot of variation between 3 patients here, but very typically this Th2 impact in the disease. Once Th2, always Th2. So it's a sustainable pattern that you see in these patients. But again, if you see eosinophils, it doesn't mean that neutrophils are not around. It's always a mixed pack. It's a mixed thing. And we have to understand why this specific type 2 inflammation is so important and has so much impact on the disease, as I will show you. What we recently saw is when you go out into the world and you look at our polyps, but also look at those in Australia, look at those in China at 2 locations, then you will find that this looking into endotypes, looking into T helper cells, is very important because you have a very wide range of different cytokines and their involvement. This is the Benelux type. 95% of our polyps are IL-5 positive or eosinophilic, as you would say. This is Chengdu, and you see it's just the other way around. Nearly 80% are non-type 2. There's a big change between these two, a big difference. Beijing is somewhere in the middle. Adelaide, this is a smaller number of patients, 33 patients, is about the same as us. They're even a little bit more eosinophilic. So it depends very much where in the world you are, what that means for your patients and how to treat them. And there's another thing where we're working on, and that is this might change over time. We have published that in Bangkok, that originally more neutrophilic polyps actually develop into eosinophilic polyps over just 10 years. So there might be a big pressure that in Beijing these polyps get to look like those in 20 years and those look like those in 20 years. And that is certainly a perspective, so certainly for the biologics to use. Now, why is that important? If we want to use these endotypes to predict comorbidity, to predict recurrence of disease, then again we have to look into the mediators we find in a group of nasal polyp patients. And this analysis here was actually to look into asthma comorbidity. What are the mediators predicting asthma comorbidity? And as you see, there's an IgE specific to Staph aureus that predicts asthma. This is a categorical value. If you look at the continuous values, IgE plays an enormous role. If that is above 1,400 in the nasal polyp tissue, it's very hard to escape from comorbid asthma. On the other hand, if this IgE is low, you are sort of protected from asthma. Very unlikely that you get asthma comorbidity. You see a small group of patients here with an maybe IL-17-driven pathway to asthma, but otherwise it's really mostly type 2 or IL-5 driven. When we look into recurrence, the second thing that interests us a lot, what we see is a very similar pattern. If we look at those patients who had surgery and then developed recurrence versus those not, again, you find the specific IgE increased, you find IL-5, ECP, and IgE. And on the other side, there is interferon. If type 1 reactions is high, you're unlikely to have recurrence. This is a study done by Philip Kiewert looking at the patients we operated in Ghent over 12 years. And this differentiates the ones without recurrence from those with recurrence. And this is actually recurrence with surgery just by one marker. This is IgE below or above 100 kilounits per liter. If you take this marker, you can very nicely predict for an individual patient whether his risk is 0 to develop recurrence in the next 10 years or is about 30-35%. Then we looked at that in the whole of Europe with the Galen sinusitis cohort group, and we looked at different centers throughout Europe, and what we found was that there is an eosinophilic part or type 2 inflammation part. There's also neutrophilic inflammation. There are several cytokines that come up within this neutrophilic inflammation pathway. IL-22 is quite interesting because it seems to be correlated to Pseudomonas infections. But what really drives the phenotype of disease, whether you have no polyps or you have polyps, and also asthma comorbidity, is the type 2 reaction. No type 2 inflammation, chronic rhinosinusitis without polyps, very low asthma. Medium or moderate type 2 inflammation, more polyps than non-polyps, and an increased prevalence of asthma. And if you have those most severe eosinophilic inflammation, type 2 inflammation with IgE, 2 Staph aureus, then you have only polyps and you have asthma comorbidity of up to 70%. So here you see how these endotypes translate into clinical relevance. There is another pathway, and it's not just the Th2 cells that produce IL-5, IL-13, IL-4, and IL-9 to orchestrate this disease, but there is this other pathway actually starting at the surface, at the epithelium, involving IL-3, TSLP, and IL-25. And this pathway also is very interesting because, of course, the nose is continuously colonized. Microbes, apart from pollutants, also might play a big role. One of the typical colonizers of patients with nasal polyps and type 2 nasal polyps are actually Staphylococcus aureus. And we have described in the past that Staphylococcus aureus is not only a frequent colonizer, but also there is quite some patients with an IgE to Staph aureus, specifically if you go to the more severe groups of patients, those with asthma, those with aspirin-exacerbated respiratory disease. We can find these staphylococci intramucosally, also intracellularly, and this is work from a group in Hanover showing also by electron microscopy that Staphylococcus is intracellular. So how could that contribute? How could that trigger the situation? What you see here is Staph aureus on the epithelium. This is an ex vivo whole tissue block. You have Staph aureus added to the equation here, stimulating the epithelium, actually partially damaging, leading to apoptosis of these cells and release of IL-33. And I want to focus on IL-33 for a moment because it may also lead to support this type 2 inflammation. If you merge it very nicely there with Staphylococcus, you also have IL-33 release. And this will lead to this exposure will lead also to an upregulation of TSLP on the gene expression level and 48 hours on the expression of IL-5 and IL-13. So we all think immediately, okay, IL-Cs maybe, there's an upregulation of the TOLAC, the TSLP receptor and the ST2 receptor for IL-33. But when you look what actually are the cells expressing those receptors, these are specifically T cells. It's just another pathway of how we can actually induce type 2 inflammation from the epithelium, and Staphylococcus might play an important role. Staphylococcus, as I showed you, Staphylococcus aureus is also inside the tissue. What we did here is we took patients' polyps directly from the lab. We washed them to get rid as much as possible of the Staphylococcus outside on the polyp. We cut the polyp and we took a swab from inside the polyp and saw whether we could or could not culture Staph aureus enterotoxins, Staph aureus germ. And then we looked at the spontaneous, without any manipulation, spontaneous IL-5 release. And IL-5 is one of the major cytokines of this type 2 immune reaction. And what you see here is that polyps spontaneously make IL-5 over 24 and 72 hours. But if you find Staphylococcus, they do much more of this. So there's a spontaneous increase of IL-5 release under these conditions. If you take antibiotics, you can very nicely suppress this. This makes sense. If you take a very specific phage, bacteriophage against Staphylococcus, you also can suppress this IL-5 production. If you inactivate the bacteriophage or you give an antibody to the bacteriophage, you can sort of get back to normal spontaneous release of interleukin-5. So it's very clear that Staphylococcus, once intramucosally, is involved in the type 2 immune reaction. And it's most likely that it does that by secreted proteins. And this is just the number of secreted proteins from Staph aureus. And you see, of course, if you don't treat the polyp tissue over 24 hours, there's a lot of those proteins. If you give antibiotics, it goes down. And here again, the phage goes down to baseline levels. And what they produce, these staphylococci, under these conditions, we can now find very nicely by proteomics, and figured out that a lot of these superantigens, but also serine protease-like proteins, are released under these conditions. So we can find them in the tissue, and we can find them spontaneously in other polyps that have not been stimulated. If you take a superantigen like SEB, you get a very broad immune answer. It's IL-5, IL-17 from gamma, and TNF-alpha is released. But if you take the SPLs, you get a very type 2 prone answer. This is especially IL-5, which is nearly as high as SEB in low concentrations, but you don't get so much IL-17 interferon gamma and TNF-alpha. So these SPLs can drive the immune reaction in the polyp, again more in a type 2 reaction. And I want to close here just saying that these serine protease-like proteins, other than staphylococcal superantigens, are, you can list them together with Alternaria, with Dermatophagoides, cysteine proteases. These proteases play a big role in the stimulation of our immune system with allergens. And they have a sort of a function of super allergens because they can also induce IgE, induce reactions, eosinophilia, if they're given together with other allergens that by itself would not cause a reaction. So the point here is that we do have different endotypes in terms of cytokine pattern, in terms of T helper cells, but we also begin to understand that there are certain mechanisms, certain biomarkers, certain microbiome parts that obviously drive this immune reaction to a great deal. What does that mean for our treatment? This is from the 2012 guidelines, EPOS guidelines, and you will find here nothing of endotypes. So this is a new concept, of course. We treat everybody with either topical steroids or topical steroids or topical steroids, right? This is one for everybody. We do not differentiate apart from, well, if we fail, we have to think about something else, and then we do surgery. I think that we have to rethink this whole concept. The Chinese did a little bit showing that topical steroids do not work so much in type 2 negative polyps, which is normal in a way. You have to have eosinophils around to be more successful in the treatment. But that is something we have to do. Then we do surgery as a next point. Well, we are used to treat the patients as long as possible without surgery, pharmacologically, and then if that doesn't work, we go to the next step. Is that correct? Maybe there are diseases where we should interfere with the surgery much earlier to actually block or stop the development into a severe disease. So the question needs to be, how large needs this surgery to be done, and when is it done in different endotypes again? Look at the endotypes of the patients instead of treating everybody alike. And then, of course, we have monoclonal antibodies. I will just summarize that there are different types that at the moment look specifically at the adaptive immune response, anti-IL-5, anti-IgE, anti-IL-4 receptor alpha, and Witzke-Fockens will go more in details there. What we really lack so far, are biomarkers. So we have started to look at a large group of the European Galen cohort and try to figure out whether we can predict whether there is, for example, SEIGE, the IgE to Staph aureus, in the polyp or not. And at the moment, we can predict that in the serum by measuring SEIGE, but also other markers like periostin, like total IgE, with a reasonable sensitivity, sometimes above 85%, and specificity up to 87%. So there is hope that at least we can exclude or we can determine those immune reactions that we see in the nasal polyp in serum. And then we would be able to apply this endotyping system much better than in the past. And with that, I want to thank all the co-workers. Galen sinusitis cohort study especially was very helpful, but also our Chinese colleagues are very helpful. It's very good to go out to the world and see at different places that you find completely different disease, and that suddenly is an eye-opener for your own disease at home. Thank you so much.